Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Nadia Harbeck. I'm the director of the Breast Center at the LMU University Hospital in Munich, Germany. Welcome to this program titled How Are ADCs Shaping the Future of Early Breast Cancer Care? Latest Insights and Emerging Strategies. I'm joined by my colleague and friend, Professor Giuseppe Curiano. Giuseppe, why don't you introduce yourself and then start us off with the guidelines?
Absolutely. My name is Giuseppe Curigliano. I work at the University of Milano La Statale and at the European Institute of Oncology. It's really my pleasure to be with you today. And I would start with the state of the art, the actual state of the art. Let me introduce the ESMO clinical practice guidelines on HR-positive, HER2-negative yearly breast cancer. Of course, the first thing to do is to establish and to stratify according to the risk of relapse. So you will have in the ESMO clinical practice guidelines a different algorithm for the luminal A-like and the luminal B-like. In the luminal A-like, if you have a low-risk disease, the standard of care should be an adjuvant endocrine therapy that can be tamoxifen or an aromatase inhibitor with a level of evidence 1 and the grade of recommendation A. If you move to the luminal A-like high risk or the luminal B-like, of course, usually for locally advanced early breast cancer, there is a recommendation to receive or a neoadjuvant chemotherapy or an adjuvant chemotherapy, followed by, in case of stage 3 high risk, if germinal BRCA mutant, of course, olaparib for 1 year. If HR positive HER2 negative, the recommendation actually for high risk is abemaciclib for 3 years, but we have also the data of ribociclib for 3 years. If we move to HER2 positive early breast cancer, usually there is a clear recommendation for any stage 2 and 3 HER2 positive disease to receive a neoadjuvant treatment. The standard of care as neoadjuvant treatment can be a combination and a sequence of anthracycline following, of course, taxane plus dual blockade with pertuzumab and trastuzumab as an alternative TCHP, so a regimen without anthracycline. Following neoadjuvant treatment, if PCR, the indication is to continue with an entire 2 therapy that can be, of course, dual blockade if not positive at the baseline, or also trastuzumab velono for 1 year. If you have residual disease, the actual standard of care is TDM1, but we saw some data at ESMO that we will discuss later. If you had a stage 1 disease, the recommendation is, of course, to proceed with surgery, and then in the adjuvant setting, if not negative, the recommended treatment should be APT, so weekly paclitaxel followed by trastuzumab for 1 year. If you have a PT2N0 or a not positive disease, adjuvant chemotherapy with or without anthracycline in not positive with dual blockade pertuzumab and trastuzumab, in non-negative with trastuzumab velono is the standard of care. Let's go now to the final recommendation for the triple negative yearly breast cancer. Again, if you have a small tumor, of course, PT1A, PT1B, or borderline PT1B, you can go directly to surgery. And then for very small tumors, you can consider also neoadjuvant systemic therapy. From PT1B to more than PT1B, usually there is a recommendation for standard chemotherapy with, of course, anthracycline and taxane, or also without anthracycline for PD1B. For triple negative, locally advanced, and stage 2 or 3, the recommendation is to incorporate a carboplatin taxane regimen followed by AC or EC in combination with pembrolizumab. Surgery will be the next step. And in case of pathological complete response, of course, indication is to 9 administration of pembrolizumab, eventually in combination with capecitabine if high, of course, residual tumor burden. If germinal BRCA mutant, of course, you can consider olaparib. Please, Nadia.
Thank you so much, Giuseppe, for outlining the current guidelines. And you're right, we're going to talk about very exciting potential changes in the guidelines very soon. So, what is the rationale for using ADCs in the early breast cancer setting? The potential for ADCs to be administered over extended periods with reduced risk of cumulative toxicities, in contrast to chemotherapy regimens that would be cardiotoxicity with anthracyclines or cumulative neuropathy with taxanes, and also the potential for de-escalation, like TDM1 versus trastuzumab plus paclitaxel, and the replacement for conventional neoadjuvant therapy. So um, I think lastly, it all boils down to precise targeting of the cells that we need to kill with the chemotherapy component in these ADCs. So, as you pointed out, we have already one ADC in clinical practice, and this was established by the Catherine trial, which randomized non PCR and HER2 positive disease, um, TDM1 versus trastuzumab. And this is the long term follow up now, which we've seen with a hazard ratio for PFS of 0.54 and an absolute difference of around 13%. So this was something that we immediately adopted in clinical practice when the first data came out. We also saw overall survival benefit for the first time, an absolute difference at 7 years of around 5%, hazard ratio 0.66. So this is a study that has changed practice immediately. The data have matured with long-term follow-up, probably also including now the hormone receptor positive, HER2 positive tumors, which we mostly see relapse after the first few years. In the Catherine, if you look at the treatment related adverse events, of course, we know TDM1 by now. We've used it also extensively in the metastatic setting. And we see that there is a little bit of increased toxicity with trastuzumab by itself, but toxicity is low. There is a little bit of peripheral neuropathy. Obviously, there is thrombocytopenia. We also have some liver enzyme increase, but all of these side effects are manageable, and patients do have a good quality of life under this treatment, in my experience. Now, in ESMO of 2025, we saw two practice changing trials in the presidential session. And the first one, which I had the privilege, the honor to present, was the Destiny Breast 11 study. It's a neoadjuvant global phase 3 study enrolling high risk HER2 positive disease. And high risk, and I think this is important for our discussion later, was defined as large tumors, 5 centimeter or larger, all nodal states, or node positive disease in all tumor sizes. And I think it's noteworthy that we also included some inflammatory breast cancers in this trial, although this was around 1%. The trial had 3 arms: TDXD, which has been very effective in the metastatic setting, now for the first time in the early breast cancer setting, either as a sequential therapy, 4 cycles of TDXD followed by THP, or dose-dense anthracyclines followed by THP as the control arm, or 8 cycles of TDXD as the standard arm. As the monotherapy arm. The monotherapy arm was closed in March of 2024 following an independent data monitoring committee recommendation. The post-neoadjuvant therapy was recommended per protocol, although left open at the end for the investigators to decide. And the primary endpoint was PCR as defined, a no invasive tumor in breast and lymph nodes. The study had reached its primary endpoint. There was a statistically significant, but I also think clinically meaningful difference of 11.2% in PCR rate favoring TDXT THP with an absolute PCR of 67.3%. And I think it's also interesting to see that this improvement was observed both in the HR positive and HR negative subgroups. The HR positive subgroup had a PCR rate over 60%, and the HR negative subgroup had a PCR rate of 83.1%. That is, 4 out of 5 patients had a PCR. At this early stage, survival data is still immature, but it's interesting to see that the curves already split with about a 3% difference at 2 years' time, hazard ratio 0.56. But I think we need to wait to see more mature data here. But I think it's encouraging to see that we see a PCR difference and also an early positive trend favoring TDXT THP for event-free survival. The other point that wasn't so clear before we had the data from this trial and also the following trial is about the safety of TDXT THP in the early stage breast cancer setting. Because if we move a drug from the metastatic setting to the early breast cancer setting, we have to make sure patients are safe. And here we saw that there was actually less high grade serious adverse events, there was less dose interruptions, and most interestingly, there was very low rate of cardiotoxicity in the TDXT THP arm, lower than in the control arm, and the ILD rate was very low, about half of that what we've seen in the metastatic setting, and was similar between the two arms. If we look at toxicities separately, what we can see is that the high grade toxicities captured here in the dark bars are lower in the TDXT THP arm. And except for nausea, the GI toxicities are quite comparable. If we look at the TDXT alone arm, which, as I said, was stopped prematurely, we see that the primary analysis shows a difference of 13.2% favoring the dose dense AC followed by THP arm. But in that analysis, every patient that switched to standard of care, which was allowed after the arm closure, was classified as a non-PCR. If we actually look at what happened with regard to PCR in a pre-specified supplementary analysis, what we see is that the PCR in the TDXT monotherapy arm is actually very similar to the PCR in the patients with the 5-drug regimen. There's a 51.4% versus 57.2%, not even 6% difference here. And most reassuring, the event-free survival looks very, very similar between the arms. So I think, but I may be prejudiced as the PI of the trial. I think this is potentially practice-changing data. And the only reason we need to discuss how we're going to move TDXT to the early breast cancer setting is because there was another trial presented right after the DB11, which was the DB05. So, Giuseppe, would you mind just summarizing this?
Yes, thank you very much, Nadia. I believe also the Destiny 5 was an important trial, a completely different setting, the adjuvant setting. This was a global, multi-center, randomized, open-label phase 3 trial for patients with residual disease in the breast or in the axilla after neoadjuvant treatment, including chemotherapy and anti-HER2 therapy. High-risk patients had been defined at presentation as inoperable, so CT4 and 0 and 3, or CT1, 3, and 2 and 3, or operable early breast cancer with axillary node positive disease after neoadjuvant treatment. Of course, centrally confirmed HER2 status positive was mandatory. 1,600 patients have been randomized to trastuzumab deruxtecan 5.5 milligram per kilo for 14 cycles versus TDM1, that is the standard of care. The primary endpoint was invasive disease-free survival, the key secondary endpoint, distant-free survival, and other secondary endpoints were, of course, overall survival, distant relapse-free, internal safety. What is very interesting is that in the trial, concomitant adjuvant endocrine therapy was allowed, and eventually also radiation therapy can be initiated concurrently with study therapy or completed prior to initiation of study therapy. Sequential or concurrent was absolutely permitted. Stratification factors were extent of disease at presentation, HER2 targeted therapy, single or dual blockade in the neoadjuvant setting, HR positive versus HR negative, and of course, post neoadjuvant pathological nodal status, positive versus negative. On the primary endpoint, the Destiny Breast 05 demonstrated an improvement in terms of invasive disease-free survival, with a 53% reduction in the risk of invasive disease recurrence or death for trastuzumab deruxtecan compared to TDM1. Specifically, there were 102 events in the TDM1 trial, the TDM1 arm versus only 51 in the TDX arm, and the hazard ratio was at 0.47. If we go, of course, to analyze other data, also here, the distant relapse-free interval, the the brain metastasis-free interval, and the overall survival was better for the trastuzumab deruxtecan arm when compared specifically for the TDM1 arm. If we evaluate the brain metastasis-free interval, we will see 26 events in the TDM1 arm versus 17 in the trastuzumab deruxtecan arm. And in terms of overall survival in this population, 29 in the TDM1 arm versus 18 in the TDXR. Of course, when we move to toxicity, we have, of course, to evaluate the gastrointestinal toxicity of trastuzumab deruxtecan. Nausea was prevalent in the arm with TDX versus TDM1. Also, more toxicity in terms of hematological toxicity of constipation, radiation pneumonitis that were 27% in the arm with TDM1 versus finally 28.8 in the trastuzumab deruxtecan arm. More liver toxicity was observed in TDM1 arm and also more thrombocytopenia in TDM1 arm. If we check now finally specific adverse event, the most important one I believe is adjudicated drug-related ILD. Overall, the incidence was higher, of course, in the trastuzumab deruxtecan arm, with an overall incidence that was close to 10%, 2% grade 1, 6.5% grade 2, 0.9% grade 3. Of course, we had also 2 patients with the grade 5, so 2 patients died in the trastuzumab deruxtecan arm. Regarding cardiac dysfunction, of course, this was really uncommon, but 2.9% were observed in the trastuzumab deruxtecan arm and 1.7% in the TDM1 arm. So now I will give back the podium to Professor Harbeck to discuss about this data.
Thank you very much. I actually brought your patient case so we can sort of discuss which of the two approaches, because they're mutually exclusive, but maybe are suitable for different patients. So I have a 36-year-old patient. She presented with hormone receptor negative, HER2 positive early breast cancer on the right side. We staged her clinically, was a T2 tumor, and plus there was a suspicious lymph node on ultrasound, which we biopsied, confirmed metastatic disease, same histology, and put a clip in for later targeted axillary dissection. We don't use anthracyclines that much anymore in these patients, so we treated her with our standard of care regimen, docetaxel, carboplatin, dual HER2 blockade, 6 cycles of TCBHP. Then she had breast conservation surgery and targeted axillary dissection. And the result of the surgery was that there was unfortunately non-PCR, although not that much. You would call it maybe RCB1, when all the lymph nodes that were removed during this surgery were free, including the one that we had biopsied earlier and had confirmed the nodal positivity. So the question is, Giuseppe, with this patient, if she came into your office and you had approvals both for DB 11 and DB05, would you use in the post neoadjuvant setting still TDM1 for this patient or TDXD?
But this is a very interesting clinical case. This is finally a patient in which I would use TDM1 because balancing the potential benefit of the post-neoadjuvant entire two therapy and the risk of toxicity, this patient, in my opinion, has a high probability to have been cured. So I would go personally to TDM1, more safe, less side effect, a similar activity because here we have really a patient in which the risk of relapse is very low, in my opinion.
Yeah. Yeah, I think that is one of the caveats with the DB05 data, and we have to wait until we see the label in its text whether the regulatory agencies approve DB05 just for the patients that could have entered DB05, or whether they give us a bit more lenient approval, which also includes patients like this one with a minimal residual disease. Because I feel in a country like Germany, where we have breast cancer screening, we don't see so much clinically inoperable patients or patients with a node positive non-PCR. So, having stated that we have probably, and you in Italy also have like lower stages, more stage 2 and not so much stage 3, would you have treated this patient with TDXT THP in the neoadjuvant setting to accomplish like 83% PCR?
Personally, in this case, in a patient like this, looking at the data of the Destiny 11, in which there was an 83% pathological complete response in the HR negative population, I would like to say that this was an ideal patient to be candidate to a regimen with the Destiny Breast 11. Again, I would like to reaffirm that in this subgroup of patients, the probability of pathological complete response was close to 82%.
Yeah, I think so too. So maybe some other questions that may come up with. So how would you select your patients that would benefit from the ADC therapy? Um, would you go just by the study inclusion criteria, or are there patients where you don't think an ADC is possible?
But personal, I believe for very high risk patients, so let's assume T3 and 1, but also T2 and 2, T4D that were eligible for the Destiny Breast 11. So these are patients for which I would consider the Destiny Breast 11 regimen because you can maximize the benefit of the ADC. You have higher probability to induce a pathological complete response. So personally, I really believe that should be the regimen. I agree with you. If you digest the data just 1 week after the presentation of the data, you really understand the value of Destiny Breast 11 because achieving that type of pathological complete response in a very hard to treat population clearly demonstrate the benefit of the addition of an ADC. So probably for this type of patients at higher risk, I would select for sure the sequence of TDX following by chemotherapy.
Yeah, I think so too. And I heard on the hallways in at ESMO, I heard a lot of people say, well, there's other trials that have equally high PCR rate. But I think one has to consider that Destiny Breast 11 has, first of all, the highest reported PCR rate in a registrational trial so far. And second, the highest percentage of hormone receptor positive patients, more mirroring what we see in clinical practice. And other trials have had like 50% hormone receptor positive patients or low risk situations. So I think we cannot cross trial compare PCR rates here without looking at the patient collective. Um, in the trials, and you pointed this out for DB05, we used CT scans at baseline and then every 6 weeks under treatment to monitor for ILD. And personally, I think given the curative setting, I would probably keep that regimen and the monitoring when drugs, when TDXT becomes available in the early breast cancer setting. Um, what do you think about the safety? Are you concerned, or would you also monitor with CT, but otherwise not be concerned too much?
No, I am not so concerned because here we are in the curative setting. So you are delivering a treatment that potentially is more active with respect to the standard of care. So since there is an additional benefit in terms of PCR, and of course this will translate for sure in event-free survival, I would accept also to give and to deliver a CT scan every 6 weeks. So personally, it's not a major concern in my opinion in this setting.
Yeah, and we'll probably see more data already at San Antonio or at other meetings where we sort of dive deeper into the DB05 and DB11 data to actually see what the time course of developing those ILD events actually is. So I have one last question before I'll ask you to sort of give us a little bit of an outlook what's out there still with trials with ADCs in the early breast cancer setting. But um, if patients, let's say you treated this patient with TDXT, THP, and then unfortunately she progresses to metastatic disease after maybe 2 or 3 years, would you then use the same sequence in the metastatic setting, or would you not use TDXT again?
This is an excellent question. After 2 or 3 years, for sure, I will use again trastuzumab deruxtecan plus pertuzumab. So my answer is yes, because you have again a probability of response. So it's of course the treatment-free interval that will determine my choice. But in the patient you suggested, I would go for TDX pertuzumab.
Yeah. I think I also would follow the ESMO guidelines where we clearly state that after 1 year of disease-free interval, you can use a regimen again. And we also put this in for pembrolizumab, but I would also go for it with the TDXT regimen. So Giuseppe, I mean, we just focused on these two trials because they were presented at ESMO at the presidential session. I think we both probably think that they're practice changing. But could you just highlight a little what other trials are out there in the early stage setting with ADCs?
Yes, thank you, Nadia. I will try to summarize which are the trials ongoing. We have the Asians 05, that is a post-adjuvant study for patients with early triple negative breast cancer and residual disease that is comparing pembrolizumab with or without chemotherapy, in this case capecitabine, versus sacituzumab govitecan and pembro. A similar study is the Aspira trial, in which high-risk triple-negative breast cancer with residual disease will receive sacituzumab govitecan and atezolizumab. Then we have the Astefania for the residual disease in HER2-positive disease, combining TDM1 plus atezolizumab versus TDM1. The Colpasser, high-risk residual disease HER2-positive, TDM1 and tucatinib, and then the Tropion-Breast 03, a beautiful study comparing datopotamab deruxtecan plus durvalumab versus capecitabine pembrolizumab. The Sasha, that is a trial not only for triple negative but also HR positive, using in the post-neoadjuvant setting sacituzumab govitecan. Then we have the attempt to TDM1 plus subcutaneous trastuzumab in the adjuvant setting. The Ferragain 2, in which you use a neoadjuvant adjuvant trastuzumab according, of course, to the response evaluated with a PET scan. The Survive Heroes, in which TDX class endocrine therapy is used as a standard of care in the adjuvant setting. And of course, the I-SPY 2, Dato-DX, durvalumab in the neoadjuvant. The MUC-DEN, in which there is an ADC conjugated with a topo 2 inhibitor plus pyrotinib. The Shamrock neoadjuvant TDX. The Talent, we saw already the data with TDX with or without anastrozole. And finally, the Torbern-Breast 04, a neoadjuvant study in which the standard of care is chemotherapy plus pembrolizumab is compared to neoadjuvant datopotamab deruxtecan plus durvalumab, followed by adjuvant durvalumab with or without chemotherapy. So this is the treatment landscape ongoing, Professor Abeck.
So thank you so much. I think we have a lot of interesting trials coming up. As you pointed out, some of these trials have already completed accrual, so we're waiting for readouts at the next conferences. So if I can probe you just for one or two sentences as a future outlook for ADCs in early breast cancer, what is your opinion?
I believe that ADCs will replace standard chemotherapy. And so, actually, you demonstrated the Vestin 11 that if you use a sequence of an ADC, a chemotherapy is better than chemotherapy alone. And the ADC alone is not inferior to chemotherapy alone. The data you showed are very clear. So, it's not negative the arm of TDX alone. And I believe they will have a major role in the post neoadjuvant setting.
Yeah, I completely agree. And I think what we've seen with the DB11 and DB05 and moving this very active ADC, trastuzumab deruxtecan, to the early HER2 positive setting uh, shows us that we can probably increase the cure rates and also have less metastatic disease. And I think that is something really worthwhile working towards. And as you showed with the outlook, we also have the trials ongoing in the triple negative setting, and I'm pretty sure that here again, chemotherapy is going to be replaced by these modern ADCs, and there are just more ADCs to come to be transferred to the early breast cancer setting. And with that, Professor Coriano, Giuseppe, I thought it was a great discussion. Thank you very much for your insight. It was great to do this with you. And I would also like to thank the audience. Thank you for participating in these activities, and please continue on to answer the questions that follow and complete the evaluation. Thank you so much.
Thank you for the invitation.